Have you been feeling off lately? Not sick, not depressed, not crazy, just different? Maybe you're waking up drenched in sweat at 3 a.m. Maybe you feel irritable for no reason, or your brain just won't cooperate the way it used to. Maybe your doctor ran some tests, told you everything looks normal, and sent you home. And yet, something is clearly not normal. If any of that sounds familiar, this video is for you. Today, we are going to talk about one of the most misunderstood health transitions a woman can go through, perimenopause and menopause, and we are going to break it down in a way that actually makes sense. Not just the physical stuff, the emotional, the psychological, the social, all of it, because you deserve to understand your own body. First, let us be clear. Perimenopause and menopause are not the same thing. Perimenopause is the transition phase leading up to menopause. Think of it as the runway before the landing. It typically begins in a woman's early to mid-40s, but research shows it can start as early as the mid-30s. During perimenopause, your ovaries gradually produce less estrogen and progesterone, the two key hormones regulating your reproductive system since puberty. This hormonal roller coaster is unpredictable and can last anywhere from 4 to 10 years. Menopause itself is the official marker, the point at which you have gone 12 consecutive months without a period. The average age in the United States is 51, though it can happen earlier, sometimes even before 40, which is called premature menopause. The years that follow are called postmenopause, and this is when health risks associated with low estrogen, like osteoporosis and heart disease, become more significant. Now the symptoms, some are physical, some are emotional, and many blur the line between the two in deeply confusing ways. On the physical side, the most talked about is hot flashes, sudden waves of intense heat, often with sweating and flushing. At night, these become night sweats that destroy your sleep. Research published in the journal Menopause found that up to 75% of women in the US experience them. Irregular periods are often one of the first signs. Vaginal dryness, joint pain, hair thinning, and skin changes are also common, but rarely discussed openly. Then there's fatigue, not the kind that goes away after rest, but a bone-deep exhaustion that persists no matter how much sleep you get. And brain fog, forgetting words mid-sentence, losing your train of thought, struggling to concentrate. Studies from the study of women's health across the nation confirmed that these cognitive changes, particularly in verbal memory and processing speed, are real and measurable. On the emotional side, mood swings, irritability, and new onset anxiety that was never a major issue before, are hallmark experiences. So is a persistent low mood that can look and feel nearly identical to clinical depression. Research from the Harvard study of moods and cycles found that women are significantly more likely to experience a first episode of major depression during perimenopause than at any other time in their lives. That is not weakness. That is biology. If a doctor has told you that you're fine, that your labs look normal, or that what you're feeling is distress, you're not alone. And you're not wrong for knowing something is off. A 2021 survey by the Menopod Society found that fewer than 1 in 5 obgyns feel adequately trained to manage menopause-related care. Hormonal fluctuations during perimenopause do not always show up on standard blood work because estrogen levels vary so dramatically day to day. Symptoms also get misattributed constantly. Anxiety becomes generalized anxiety disorder. Depression gets medicated without anyone asking about hormones. Brain fog gets blamed on stress. And women of color face additional barriers. A 2023 study found that Black women in the US experience more severe and longer-lasting symptoms than white women, yet receive significantly less treatment. Estrogen is not just a reproductive hormone. It directly influences serotonin, which regulates mood, dopamine, which drives motivation and pleasure, and GABA, the brain's natural calming system. When estrogen drops, all of these are affected simultaneously. That is why the emotional experience of perimenopause can feel so destabilizing, because it literally is. The symptoms can meet the clinical criteria for depression and anxiety: persistent low mood, loss of interest, difficulty concentrating, fatigue, sleep disturbance. When these are treated in isolation without addressing the hormonal root cause, women cycle through treatments that only partially work. If you have ever been told you are just being emotional or overreacting, what you're experiencing has a neurological and hormonal basis. You are not losing your mind. Your brain chemistry is changing. The impact extends well beyond the individual. Relationships with partners, children, and colleagues can all be strained when symptoms go unaddressed. And culturally, in Western society, menopause is too often framed as decline and loss of femininity, messages women absorb everywhere. Research shows that women in cultures that associate menopause with freedom and wisdom actually report fewer distressing symptoms. The meaning we assign to this life stage shapes how we experience it. Globally, approximately 1.1 billion women will be postmenopausal by 2025. In the United States, around 6,000 women enter menopause every single day. You're not alone in this. Unmanaged perimenopause and menopause do not just stay uncomfortable. They open the door to serious health complications. Chronic depression and anxiety, increased risk of cardiovascular disease from ongoing sleep deprivation and estrogen loss, accelerated bone loss leading to osteoporosis, abdominal weight gain that raises the risk of type 2 diabetes, and genitourinary syndrome, vaginal dryness, urinary urgency, and recurrent infections that affects over half of postmenopausal women. These are not minor inconveniences. They are physiological events with real downstream consequences that deserve real medical attention. Menopausal hormone therapy remains one of the most effective evidence-based treatments for hot flashes, mood symptoms, and bone loss. Concerns from the early 2000s Women's Health Initiative have largely been recontextualized, updated guidance from the menopause Society confirms that for most women under 60 and within 10 years of their last period, the benefits outweigh the risks. It is not for everyone, but it should not be dismissed. Cognitive behavioral therapy, or CBT, has strong research backing. A 2019 randomized controlled trial in psychosomatic medicine found CBT significantly reduced hot flash distress and improved mood and sleep. It works by shifting thought patterns that amplify distress and building lasting coping skills. Antidepressants, particularly SNR is like venlafaxine, paroxetine, and escitalopram can manage mood symptoms and reduce hot flash frequency. Paroxetine is actually the only non-hormonal medication FDA approved specifically for menopausal hot flashes. Side effects are real though. Weight changes, decreased libido, emotional blunting, and sexual dysfunction. Any medication decision needs to be a genuine conversation with your provider, weighing both benefits and costs. What does not work? Suffering in silence, dismissing symptoms as aging, and leaning on unproven supplements. Some women find relief from black cohosh or phytoestrogens in soy, but the evidence is inconsistent. These should not replace evidence-based treatment when your quality of life is genuinely affected. Even before seeing a doctor, there are real things you can do. Exercise is one of the most powerful. Aim for 150 minutes of moderate aerobic activity weekly plus resistance training twice a week. For sleep, keep your bedroom cool between 65 and 68 degrees Fahrenheit. Avoid caffeine after noon, limit alcohol, and stick to a consistent sleep schedule. Nutritionally, prioritize calcium, vitamin D, and magnesium through leafy greens, nuts, and seeds. And practice mindfulness. Even 10 minutes of intentional breathing or meditation daily has been shown to reduce hot flash severity and lower anxiety over time. CBT with a trained therapist can genuinely transform this transition. But accessing therapy is not equally easy for everyone. In the US, costs are high, waitlists are long, and rural areas have limited options. For women from cultures where mental health struggles should stay private or are seen as weakness, the barriers are personal and relational, not just logistical. Telehealth and online CBT programs have expanded access significantly and have real research support. If medication is on the table, go into that conversation informed. Ask about side effects, ask about hormonal factors, and if you feel dismissed, you are allowed to seek a second opinion or ask for a referral to a menopause specialist. Before we close, I want to say something that often goes unsaid. A lot of women feel deep shame about what they are experiencing. They wonder if they are weak, why they cannot just handle it, or feel guilty about how symptoms affect the people around them. Hear this clearly. You are not weak. You are not failing. You are going through one of the most significant hormonal shifts of your life. Largely without adequate support or acknowledgement, the fact that you are here trying to understand what is happening, that is not weakness. That is wisdom. Perimenopause and menopause are not the end of anything. For many women, with the right support and information, this transition becomes a turning point toward greater self-knowledge and authenticity. Talk to your doctor, and if they dismiss you, push back or find another one. Try the lifestyle strategies. And please, be kind to yourself. If this video helped you, share it with the women in your life. The more openly we talk about this, the less alone any of us has to feel. Subscribe for new videos every week on mental health, well-being, and real-life transitions. Hit the notification bell, and we will see you in the next one.